to get all the information that we need, and then discuss the histological features to look for in order to complete histological risk stratification and local staging of the tumour. So as Dr. Hu mentioned, there are many different types of pediatric renal tumour, and just this one slide will show you how different these look histologically, and indeed they behave very differently as well. Top left is a triphasic nephroblastoma, bottom left is a congenital cellular mesoplastic nephroma. In the middle we have a translocation associated carcinoma with very wild pleomorphism. Top right is a papillary renal cell carcinoma, and then we have a malignant rhabdoid tumour at the bottom on the right. So Wilms tumour, though, does account for the vast majority of these cases, either localised in 72%, adding another 10% to these with metastases, and then 7% with bilateral Wilms tumour. We can see that that really makes up almost 90% of the total, leaving congenital mesoplastic nephroma, clear cell sarcoma of the kidney, MRTK, and others, including PNET, for example. There is an age-related distribution. We've just heard that from our last speaker also, and so as soon as we hear from our oncologists, and we have a very tight communication in our team, or multidisciplinary team, so usually our surgeons tell us in advance before they're going to biopsy something, so we know to stick around and await the biopsy fresh. Our oncologists tell us as soon as they hear from a peripheral source that a patient may be coming in and has a mass in the kidney, for example. And with that knowledge and the age of the patient, we can already start thinking about what we are expecting in this particular case. So the presentation, as was mentioned, is typically with a mass in the abdomen, and often it's the parent that will feel this because we're talking about a rather young child, and this may be while they're bathing or dressing the child. Usually the next step is abdominal ultrasound scan, which identifies the kidney as the origin of the mass. There is a move away from upfront diagnostic biopsies, even within CEOP. COG have been against that for quite a while. They believe in primary resection where that is safely doable. Historically, by CEOP protocol, we did do a biopsy, make a diagnosis, institute chemotherapy, and then go for a post-chemo nephrectomy. But except for cases where the presentation, either clinically or radiologically, or a combination of the two, suggests that a case may not be a nephroblastoma, we do not do biopsies on the cases where we think it is likely to be nephroblastoma, and so the patient will have chemotherapy up front and then undergo nephrectomy after that. Except in patients that are very young, so under the age of 6 months, congenital mesoplastic nephroma and rhabdoid tumour are serious considerations. And as I mentioned yesterday as well, cases with a suspected MRTK should undergo a CNS scan as well to look for a synchronous ATRT in those patients. If there's very bulky lymph node evidence on scanning, this suggests renal cell carcinoma, and therefore, as this is not chemosensitive, the patient really should undergo nephrectomy with lymph node dissection up front. In older patients, we may consider renal cell carcinoma and possibly CCSK also more likely than a Wilms tumour. So otherwise, we follow either the CEOP protocol as we do in our hospital, or of course, if you're based in North America, I'm not sure, but it sounds like you're following CEOP here as well. Otherwise, you may have the children's oncology protocol, and there are some differences between these. So CEOP, as I say, have moved away from an initial diagnostic biopsy and now advocate chemotherapy up front for the suspected nephroblastoma and then resection. So the protocol is for 2-agent chemotherapy for a duration of 4 weeks if we have evidence of localized disease on scanning, and 3 agents for 6 weeks if there's evidence of metastatic disease, and then resection. And at that point we can see whether there's a good response and whether in fact we are dealing with nephroblastoma histologically. COG advocate upfront resection of the tumour if this is safely doable. Both will involve post-operative chemotherapy regimens, also depending on the histological risk classification and the stage of the disease. So The next part of my presentation is really largely directed at pathologists, but I think it's useful for everybody to be aware of this. So nephrectomies, really, when we receive these, we should, as pathologists, look very closely at the gross specimen, and we consultants look at them ourselves. We obviously involve our trainees as well, but it's important to weigh the specimen to get the maximum dimensions of the entire nephrectomy, and subsequently on cut surface we want to know the dimensions of the tumour as well. Before we cut the specimen, we need to look very closely to see, is it an intact specimen, is there evidence of rupture, and if the rupture occurred pre-chemotherapy, then that involves a more multidisciplinary approach, in fact, to establish whether that is likely the case or not, as there would be scarring and repair, if you like, following chemotherapy, and it may not be histologically as obvious. We take photographs of our fresh specimen. We then ink the specimen. I mentioned yesterday with the soft tissue tumour resections that in order to evaluate the margins, it is incredibly important to use ink. This has to be applied before the specimen is opened. If you open the specimen and then ink it, the ink can leak into the specimen and give you the wrong interpretation of what's going on. So visual inspection is important, but it's not the be-all and end-all. It is not really sufficient. What you need is on your class slides to be able to see the inked resection margin to see if the tumour is completely excised. At the stage of receipt of the specimen, we should also be looking closely to see are there any lymph nodes in the renal hilar soft tissue, and often our surgeons will give us the nodes separately in different pots labelled with where they actually come from. But we should still look closely at the hilum. Now, we try to open the specimen, and often these are very distorted, given that they can be very large tumours, sometimes in small kidneys, and it may be difficult to find the hilar plane, but it is really very advantageous to find that, because it makes your sampling much easier subsequently. So once we open the specimen, we will have a look grossly at what we suspect is the necrotic component, how much percent necrosis is there grossly, and this is usually based on a yellowish discoloration, maybe some hemorrhagic change. We don't tend to see a lot of calcification in nephroblastomas, unlike neuroblastomas, but certainly the yellowish discoloration can, and this is only a gross estimate, it's not going to go anywhere specific, but they do look for it on the forms that you will fill in if you're taking part in a clinical trial, filling in the forms for that. Gross capsular breach is very important to note, and also you may grossly see evidence of nephrogenic rests if these are hyperplastic, and these should be recorded and obviously sampled. You may not find them until you get to the histology though, if they're quite small. Again, we tend to take from our fresh samples some material to snap freeze, and this is useful for looking for loss of heterozygosity of 1q and 16p specifically in these tumours, and so we can snap freeze it and store it and then share it with our cytogenetics lab, who will carry out our ACGH as I described in the last talk. Then we will fix the specimen, so once we've cut it in the right plane, we will fix it, often put tissue paper in there to allow it to really get a good fixation, and then the following day take a look at it, take more photographs typically, and then sample one full face of the kidney, including the surrounding normal uninvolved renal parenchyma, plus any nephrogenic rests there may be, and also, of course, an entire face of the tumour. And you should do that even if it looks like it's completely necrotic. It doesn't matter, we need one full face for proper evaluation. So you all know the anatomy of the kidney, and the reason we're so interested in the hilum is because this is where the capsule is deficient. It's where the vessels go in and come out of the kidney, and where the ureter exits as well. So the dark brown indicates where we have capsule, and in the hilar area you can see this is deficient, and this is really important to evaluate carefully the sinus, the soft tissue of the sinus of the kidney, in order to establish whether we have invasion of tumour into that sinus, because that is relevant for our staging potentially. So the red arrows just indicate where the capsule ends, and the blue indicate the area of the sinus soft tissue. That's important for evaluation. But again, you need to take a full face. So here's a nephrectomy specimen that we received, photographed fresh. You can see it's very distorted, and the lower half on the left side, if you like, is all tumour, but the capsule is intact, and we have the kidneys poking out at the other side. That's the contralateral aspect of it. And having opened it, this is what we have. So we inked it first, we then opened it, and this is what the fresh nephrectomy looks like. The sort of tan colour that you can see depicted here in the bottom right and bottom left is fleshy, viable tumour, and you may suspect that much of the rest of this is likely to be necrotic. It's very yellow with a bit of hemorrhagic discoloration as well. We then do our grid diagram. This is the way I do it, and it basically just involves using an acetate sheet, place it on the tumour, make a grid, indicate where you're taking your blocks from, and that means that anybody else coming back to the case later, looking at it, can understand exactly where your sections have come from. But also, if you need to go back and sample deeper in an area of sinus soft tissue, you know exactly what area you're concerned about, or indeed for capsular penetration by the tumour. So the histological evaluation then of pre-treated nephrectomy will lead us to local staging of the tumour, pathologic staging if you prefer, and also risk stratification. And these are important because they will determine how the patient is treated post-nephrectomy with ongoing chemotherapy if that is necessary. So just to remind you what the histology looks like briefly, this is a triphasic nephroblastoma. So we've got a combination of tubular structures that you can see. We've got abortive glomeruli protruding into these open spaces. And then we have some blastema here, the clusters of blue cells, round blue cells, as mentioned from the last, and stroma as well. So the stroma is, so the epithelial elements include the glomeruli and the tubular structures. The blastema is self-explanatory, and then stroma can sometimes be difficult to tell apart from post-treatment aggregation of macrophages that might look spindly. So that's an important thing to try to work out. So literally looking at the slides post-nephrectomy, you will record per slide. I actually just usually make a little table for myself, and per slide I have headings on my little grid diagram: necrosis, epithelial, blastema, stroma, and then per slide they should all really be approximately the same size because you're going to look for the optimal percentage. You will record how much necrosis there is on each slide, how much epithelium, what proportion of blastema, and so you will come to a conclusion. So this is stroma, and we've got skeletal muscle differentiation here, very large pink cells with eccentrically located nuclei. And then this is a combination of epithelium, necrosis towards the right side, stroma, and also blastema in little rounded buckets there on the upper left aspect. We should also look for anaplasia. So I mentioned anaplasia in the context of verbal rhabdomyosarcoma, where it is extremely important and may be indicative of a p53 mutation, not necessarily germline. But similarly, anaplasia is important in nephroblastoma, and if this is diffuse, it increases the risk stratification to high risk, either by COG or by COG criteria. Focal anaplasia is defined somewhat differently between the COG and the COG protocol, simply because you've had pre-treatment of the case in COG. This is what anaplasia will look like. So we've got a pocket of blastema, and within this we have nuclei that have very atypical mitotic figures, and there are very strict criteria for making a diagnosis of anaplasia. So you should have a mitotic figure where at least one arm of that mitotic figure is the same size as a normal mitotic spindle. So this isn't just, oh, that looks a bit odd, I think I'll call it anaplasia. It's very, very clearly defined, and it should be combined. You should have these atypical mitotic figures together with anaplastic nuclei, which means the nuclei should be at least 3 times the size of a normal nucleus, often lobulated and hyperchromatic. So you need to have both of those features to call definitive anaplasia. You should not overcall what we call nuclear unrest, which again may be associated with p53, but does not increase the categorization to diffuse anaplasia and a higher risk frequency. Here's another example of anaplasia. You can see a pentaneuromitosis there in the middle of the field, and another one again. So The histological classification then will give us our risk stratification for the patient. Low risk, just to make it really simple and brief, low risk includes cases where we have complete necrosis post-chemotherapy with absolutely no viable tumour left. Residual nephrogenic rest elements are acceptable. Cystic partially differentiated nephroblastoma is also included here. So this is not the same thing as cystic nephroma, and it's not the same thing as cystic Wilms tumor either. These are both low risk categories of renal tumor. High risk implies diffusely anaplastic cases and blastemal cases. And I'm going from here on with the COP classification because I think it's going to be too confusing if I flip back and forth between COP and COG. The blastemal cases by the COP criteria involve more than 33% of the viable tumour. So you need to look again at your full face, you need to work out where you have viable tumour and what proportion of the viable tumour is blastema. So it needs to be more than 33%. For that to be more than 66% blastemal of more than 33% viable tumour. All other cases then fall into the intermediate risk category. So to tabulate this then, we have complete necrosis, where CIC is chemotherapy-induced changes, then we have blastema, epithelium, and stroma. So this is effectively a table summarising the findings in a case. And as I say, I do it slide by slide and then do a calculation at the end. Regressive, mixed epithelial and stromal are all intermediate risk. So in these cases, we have a proportion of chemotherapy-induced change, but in the cases where there's more than 66% chemotherapy change and zero, any level of blastema, that's a regressive tumour. If it's mixed with less than 66% of chemotherapy-induced change, it depends then on the other elements within the tumour as to whether it is regressive or not, whether it's intermediate risk. And then epithelial is where we have 66% to 100% of the viable tumour is epithelial in nature. And stromal is where we have 66 to 100% that is of the viable tumour that is stromal. So again, it takes a very careful review of the total percentage necrosis and what elements you have within the viable tumour, and then you can classify this by risk stratification. Blastemal then is where you have above 66% of the tumour is still blastemal within the viable component. Per COG, because we've undergone a primary nephrectomy, it is a slightly different calculation. So favourable histology, meaning no anaplasia, is considered low risk. Intermediate risk can include focal anaplasia but not diffuse. And then high risk would be diffuse anaplasia or unfavourable histology otherwise. We should also look for evidence of nephrogenic rests, and this came up in our case discussion yesterday where there are bilateral or multiple lesions within a kidney. We should be thinking, is it possible that this patient has some sort of predisposition and has some nephrogenic rests in the background? These come in two forms, either perilobar or intralobar nephrogenic rests, and because the kidney is formed of 8 lobes that fuse, perilobar does not just mean under the capsule, it can also be actually internally within the kidney, but at the edge of these lobules. And then intralobar rests, these also look histologically different. The nephrogenic rests may undergo hypoplastic change, and that is a precursor for nephroblastoma. So we know from looking at series of cases that 1% of autopsy cases where you sample the kidney will show nephrogenic rests, but in fact it's 30 to 45% of cases of nephroblastoma, and therefore we know that there is an association with the development of nephroblastoma, and indeed many cases with nephroblastoma may have rests in the background also. This is an example of a regressed or a an obsolescent nephrogenic rest, so the little triangular pinkish structure is essentially scarred down. That was once upon a time a nephrogenic rest. Here we have some small hyperplastic rests, so they're very cellular, perilobar in location directly under the capsule. And here we have a very nice section. It's a slice of a nephrectomy specimen. You can see the obvious nephroblastoma. There's some necrosis and some hemorrhage within it. And then in a subcapsular distribution, we have several whitish nodular lesions, which are nephrogenic rests, hyperplastic nephrogenic rests. And this is what they would look like histologically. And then if this becomes a very extensive phenomenon involving really the whole kidney, we talk about nephroblastoma. This is what that might look like grossly. So if we see multiple nephrogenic rests alongside a Wilms tumor, as I say, this implies a potential predisposition to nephroblastoma, and it is essential that the contralateral kidney be considered a field at risk, if you like, tissue that could have a field effect as well, where there may also be rests within that. And this is where nephron-sparing surgery may come into play if we feel that the contralateral kidney is also at risk, or indeed, of course, already involved by a tumor. So Dr. Hung very nicely went through the local staging, and you can see the criteria are very clearly laid out in this table. So we have stage 1, where viable tumor is limited to the kidney with negative margins and lymph nodes, and all of the criteria listed are met. Stage 2 is where the margins are negative for viable tumor, and the lymph nodes are negative for viable or non-viable tumor. At least one of the following criteria though has to be present. So when we talk about margins, we're talking about vascular margins, ureteric margins, and then of course any hilar soft tissue margins as well that could be observed on each sections. Stage 3 then is residual non-hematogenous tumor present after surgery confined to the abdomen, and any of the following criteria listed below there, and these are obviously very readily available criteria for you to look up. Sinus invasion can be quite tricky to identify. First of all, one has to understand what the sinus is. I've given you a gross cartoon image of a kidney and indicated where the capsule is deficient. That's where we have sinus. From the pathologist's point of view, it's important to understand where exactly that is as well. And again, this will be determined by how well you've cut the specimen as to whether you've really got into the hilar plane in order to evaluate this. So you can make life very difficult for yourself, and sometimes that's beyond your control, if you don't get a nice hilar plane. But the sinus is the soft tissue essentially between the vessels and the ureter. And within the sinus, we tend to find significantly sized nerves, and for us as pathologists, that's really, really helpful to know that you're not just looking at another area of soft tissue. And again, if you're not in the best plane, these can be extremely helpful. This is a sinus area. We've got ureteric epithelium lining the structure at the top left, and then soft tissue, and poking in a pyramidal structure at the bottom is pre-treated nephroblastoma. So this is evidence of sinus invasion. That's at a slightly higher power right there. And again there. Sinus vascular invasion is also very important. So the vessels within the sinus need to be looked at carefully, and evidence recorded if there is tumor within these. And again, it's very important that before opening the specimen you ink it and then fix it and then take your sections. That way one would hope that you will not be pulling soft friable tumor into the vascular spaces, but that needs evaluation. And again, if you find ink within one of these vessels sitting on tumor, you should think, well, that's probably not, it's almost certainly not real. You can always cut deeper levels and take more sections from the tumor. We need to look at the intactness of the capsule and for evidence of rupture, but as mentioned, that's really a multidisciplinary consideration, including radiology. If the patient had rupture at presentation or shortly thereafter, then there will be clinical evidence also to suggest that. So it all has to be taken into account, because, as I say, a rupture may heal over and be rather difficult to establish histologically, so you need to put that together with your clinical radiological information. So a sample report may look like this per CEOP system, and this is how we tend to report our cases. So we'll give the diagnosis for the nephrectomy, we'll give the margin status, and we'll give the stage. We'll indicate the risk stratification. And then if there's a skin biopsy site, for example, we will report that separately. And as I mentioned, our surgeons will give us the lymph nodes in separate pots sometimes, so we will specifically indicate where they're from and how many nodes were positive or negative. I was involved with the International Consortium on Cancer Reporting for both rhabdomyosarcoma and renal tumours in the last year or so. These have been published now, and these links are possibly useful if you wish to consult them. The idea behind this is really